Fellowship Fellow, and I'm primarily at UPMC Shadyside. Fortunately for you, I am actually the last fellow presenter, and I'd like to tell you about my home visit curriculum that I've been implementing at UPMC Shadyside. My project was supported by a competitive research fund at Shadyside. Today, I'd like to outline my project by providing a background and rationale of why I chose to do a home visit curriculum, my methods of what type of curriculum, how I made it, and how I chose to measure it. I'll be talking about my results and about my curriculum assessment, and lastly about my conclusions and implications. So why did I choose to do home visits as my project? I feel that home visits are very important on a number of levels, and I'll be talking about them through the following steps: from a societal level, a patient level, residency program level, and for a resident. First of all, society does need home visits. As we know, there's more older patients with more chronic disease. There's a challenge for Medicare already in sustainability, and we know that we already spend $17 billion annually on unnecessary readmissions. And in recent years, there have been more publications that show that home visits can reduce readmissions, admissions, and ER visits. On a patient level, we know that a lot of our patients are very complex. There are patients that are homebound, and some of them, we only meet them when they're in the hospital. And when they're in the hospital, their duration of stay is shorter than it used to be, and they're quickly discharged either to a skilled nursing facility or to their home. And I think a lot of us are actually very concerned about them once they leave the hospital. How are they going to manage? And then there's a cohort of patients that have really poor medical adherence. Either they aren't able to make it to the office for various reasons, or it could be poor adherence to medication specifically. In terms of how this is important from a program's perspective, until recently, until July of 2014, the ACGM required each family medicine resident to complete 2 home visits by the time of graduation on their own continuity patients. And since July of last year, they've changed the wording. So now what they say is, it's not a 2-visit requirement, but each resident should be able to take care of their own patients in all kinds of environments, including the home. So I think this change of wording is more consistent with competency-based practices, instead of saying 2 is enough visits for every resident. Speaking of competency-based evaluations, now we're looking at the milestones. And for a residency perspective, it's hard to see how we're going to evaluate each resident in different milestones. And with a direct observation of skills of a resident performing the home visit, we can assess 13 of the 22 milestones and competencies. And I don't have time to talk about all of these today, but I looked through each of the competencies, the sub-competencies, and these are the ones that I listed on the right side, which ones that could potentially be evaluated by watching a resident perform a home visit. In terms of how this can be important for residents, well, we all know that we practice within our own comfort zone. So it's less likely that we'll do something after we finish residency if we haven't developed the skills and the comfort or the competency to do them while we're in practice. Interestingly enough, also, home visits are becoming a more specialized area of medicine, kind of like sports medicine or geriatrics. And the number of home visits has actually doubled from 2000 to 2006. And you'll see that more physicians, there's an increasing number of physicians that especially focus on doing home visits as part of their practice. So I think that family medicine residents at least should have some exposure to home visits during their residency training. And last but not least, home visits can be a very rewarding experience for both the physician and the patient. I think that now we only have either 15, 20 minutes to see each patient during their office visit, and with all the pressures that we have to complete best practice measures and to check off every box that we're supposed to do, a lot of times our practice is not very satisfying. We don't think that we're doing the best for our patients. And home visits have a way of kind of filling the gap in what we think that we should be doing. In terms of why I thought this was important to do at Shadyside. I did my residency at Shadyside, so I kind of understand what the residents are going through. What we had before in terms of our home visit training was nothing. We didn't have any formal education or no formal structured curriculum. And at Shadyside, we were required to do 3 home visits on our own patients. We were supposed to choose our own patients and just go and do them on our own. So basically, this is what happened. This is a trend of the third-year residents, and because nobody ever did home visits anytime else in residency. And as you can see, on the left side is July, so the beginning of third year, and the right side is June when they graduate. And you can see that most home visits were done just prior to graduation, just so they could get their numbers. And I am actually included in this list. So I can't blame others. But anyway, I thought this meant that my hypothesis about this was that residents had a poor attitude toward home visits as just a requirement or a checkbox that they had to fulfill. And I thought that if we learned more, or we were able to get more formal training during residency, it would help us in change the way that we perceive them. So next I'll be talking about the curriculum, which was my intervention, and how I chose to measure this. I built my home visit curriculum based on what's called the KEP model. The KEP model helps you create a curriculum that's well balanced, and you have to think about all these components. I don't have time to talk about all of these things, but I'll talk about the 2 things in red that I think will help you understand what the curriculum was made of. So in terms of content, the curriculum structure, it was incorporated into a 4-week community medicine rotation during intern year. It included a 1-hour orientation, kind of a discussion session with me, with 2 residents at a time. And I, myself, or another faculty member would go on the home visits and supervise the interns when they saw their own patients in their home. And this included preparation and debrief of the home visit. So in terms of faculty time, this meant 2 half-days per intern and 1 faculty member. For the teaching and learning activities, my expectations for the residents were to choose 2 of their own patients that needed a home visit. And the reason why I had them choose their own patients is that I thought it would be really helpful for them in their future patient care instead of seeing somebody else's patient. I had them set their goals for the visit, review their trying chart, and communicate with the home visit team. The home visit team is basically the attending, the resident, and we always had a pharmacist. So it could have been a pharmacy faculty member or a pharmacy resident or a student that was well prepared. The 2 home visits were conducted under direct supervision, so I had the resident lead the visit, but we would be there for support. And then we would come back and debrief and they would document the visit. The way I measured my outcome of whether this curriculum actually helped or made a difference is that before the curriculum, I had them do a survey. 16 interns completed the curriculum, and then I had them do a post-survey. What I really wanted to focus on was to see if there was an attitude change after doing this really brief, kind of simple curriculum. The attitude survey was kind of comprised of 10 Likert scale questions. A few examples were physician home visits have a valuable role in patient care. A team approach is valuable to providing home care. And I feel adequately trained to do home visits on my own. Some other questions were, I would be more likely to do home visits after residency if I had more opportunity to do home visits during residency, or if I saw more faculty members doing them during residency. And I asked them how many of them planned on doing home visits after residency. I also included a free text question that says, ask them to state one thing you have learned from doing home visits that will help you in future patient care. So next I'll be going over the results. I was able to collect the surveys from all the PGY1 interns that completed my curriculum. Interestingly, most of them were female, and their mean age was 29.2. I asked them how many visits they've done as a medical student. The median number was 2. There were 4 people that said they've done more than 10 during medical school, none of them had really done any home visits after residency, since residency started. And I asked them, in this past 6 months, how many patients have you seen that you thought could benefit from doing a home visit? 1 said 0, 12 said between 1 to 3 patients, and 3 said between 4 to 6 patients. I wanted to know what they planned on doing after residency, and since they were interns, you'll see that there were most of them said group practice, but a lot of them said I don't know yet too, and followed by some that said fellowship. And I said you can answer as many as possible. So just to get an idea, this is what they responded to, and this was my main results page. And because I asked them to answer the questions on a Likert scale, you're really not supposed to get a mean because it's an ordinal scale, but I only had 16 residents, so I really want you to, as Frank would say, look at the data and the numbers, because this will tell you the most about what my results were. So I'm going to show you the pre and post means, the mean difference, and actually, what I want you to look at is the pre and post, the general trend, by looking at these 2 columns. So you'll see a general upward trend. The mean difference was where you would actually see, calculate whether there was a significant change. And my p-values were based on a Wilcoxon sign ranks test, based on the median scores. Interestingly, a lot of the questions, so these are all questions that if you responded higher, that is a positive response. So a lot of the questions, actually, residents responded to favorably even before they did the curriculum. So you'll see that they thought a team approach was important in home visit care, and questions 6 to 8 were about what would help them do more home visits after residency. So question 6 was, if there was a home visit team at my residency program, I would be more likely to do them. If I did more home visits during residency, I would be more likely to do them after residency. And if I had more training on the logistics, I would be more likely to do them. And these were the same before and after the curriculum. So actually doing the curriculum made them, there was no change. The significant p-values, as you'll see, was on these different questions. And I want you to specifically focus on question 3 and 4. And these were questions that asked, do you feel adequately trained to do home visits? And are you comfortable to do home visits on your own? And these were the questions where you would see the most change. And the median change in I feel adequately trained was 2. I also asked them, as I said, what do you feel was important in learning during this curriculum that will help you with your future patient care? And I wanted to share some quotes that I got from this question. One resident said, how eye-opening a home visit can be. Another said, we can never assume that patients are compliant or they're doing well. Another resident said, the ability to see a patient's limitations firsthand is very valuable. And a particularly successful home visit I thought was kind of illustrated from this quote. A resident said, after doing the home visits, one of my patients really understood why we were worrying about him. He became motivated to control his sugar, compliant to medication, and takes care of himself. If we can get our patients motivated by doing home visits, I strongly believe it's worth doing, although it does take time and effort. So in conclusion, some attitude changes that we were able to see with the curriculum is an overall positive trend with the curriculum. Residents felt there was an important role for the physician in doing home visits. And because of the curriculum, they felt that they were significantly more trained and more comfortable in doing home visits on their own. Some limitations of this is that, it's a small sample at one institution. The timing of when I did the curriculum, so, it might be different from doing at the beginning of intern year versus doing at the end of intern year, might impact the outcome. There's a lot of other confounding factors during residency. You grow but doing a lot of different things during residency, so the home visit curriculum might not be the only thing that might impact this. And we're yet to know the long-term impact of doing this curriculum. We don't know whether they're going to actually do them after they complete their residency. Some positive implications is that if residents feel well-trained and comfortable performing home visits, they might do more after residency training. And it's a simple curriculum. and this might serve as a model for other family medicine residency programs. And what I also found is that a home visit supervised can be utilized to evaluate many of the milestones, which might be a valuable thing for residency programs. I'd like to acknowledge the following people. It's my home visit team and my mentors. And now I'd like to open the floor up to any questions. Yes, Dr. Southwell.
I thought this was exciting just to hear this presentation you were going to learn about the implications of a different mechanism of practice that we haven't been doing enough of in recent years. Given your experience with home visits in Japan and home visits here, I'm curious as to a sense you might have from listening to the comments, from looking at your data, the number of visits. Because as you mentioned, the uptake was at the end of the third year trying to meet the requirement. But I thought your idea of saying, visit your own patient, because longitudinally that can be more beneficial because you're getting to know your own patient better. What is your sense about, should this be an annual sort of thing, or should it be done more frequently? What would you think, just given the types of outcomes you were looking at?
So I think I'm hearing your question as what's the appropriate structure of doing a home visit and how we should incorporate it into our residency training. So there was a comment about my experience in Japan, and in Japan there's a lot more elderly patients, and I think there's more of a population, a set population that will not ever be able to make it into the clinic. And I think relatively speaking, our patients that we see at the family health centers, it's not that they're completely homebound most of the time. There might be some reason that it could be a psychosocial reason that they can't make it into the clinic. So I think there is utility in creating a patient panel, a pool of patients, of elderly patients or patients that cannot make it into the clinic, and seeing them as a practice. And there's also utility in seeing your own patients, selecting a few that you feel like would help you make a real connection with, or create that motivation to come into the office. So it's hard to say which is better, but I think there's a place for both types of visits. Yes, Chris.
So prior to your curriculum, you said it was kind of just do your home visits on your own. Was there any guidance or any supervision, any tutelage prior to that, or are they just like you have to do home visits, figure it out?
So the question is, what type of instruction were we receiving before this curriculum was implemented? And I have to say, even this is my own program, there was not a lot of guidance. It was mostly, do your 3 home visits before you graduate. If you need any information, talk to your advisor. So residents that followed that may have gotten more input than others who just went to the home not knowing what to do at all.
So we've heard today a lot about the potential and excitement about involving pharmacists in various clinical activities that physicians do. So with regard to home visits, the group that I think of are social workers, because social workers receive so much training about home visits and might have other value added. So I was just wondering, what your thoughts are about potentially involving social workers, either in the training process or actually in the implementation process, and what possibilities there might be there.
Thank you. The question is about how we can utilize social workers in our home visit team, and I think that that's an incredibly important person to have, I think, as part of our team. And in the future, this project actually has triggered our practice to kind of reflect on the services that we provide. And what we're trying to do now is one of our next steps is create, receive some grant funding so we can actually have funding for a social worker on our team, because I think there is a lot that the social worker can bring to what we can provide overall that the physicians and the pharmacists just know nothing about. So I really hope that we get that funding so we can add them to our team.
I don't know anybody who knows more about home visits than you do, Tomoko. And so if I was on the ACGME or the RC and I was making some guidelines for home visits in family medicine residency programs, I would invite you to be on there. So if you were setting the policy for the role home visits should play in residency training, what would that look like? Would it be a set number? Would there be some observation? What would your recommendations be for how to specifically incorporate them into the residency training process?
That's a very good question. So the question is about how we would incorporate home visit training into how we would evaluate home visit training in our residency. And I think that, I don't think it is going to be a set number, because I do think that each resident reaches competency at a different level, at a different pace, and by doing a different number, and it's not just a number that will make you competent. I think that the direction that the milestones has taken is probably the most useful also to use in evaluating residents. So, and I think that the only way that we'll know if they're competent is actually seeing one. So direct observation is probably key to see if a resident is actually able to transfer the skills that they've obtained in like an office or an inpatient setting to the home. And maybe there might be a way to evaluate them based on like a milestone